Good morning. I am Dr. Paridhi, here to present a case on suspected focal frosted branch angiitis due to a retained metallic intraocular foreign body. Frosted branch angiitis is the name given to the retinal vessels because they resemble the ice-covered tree branches also seen in CMV retinitis, but it is not only typical to CMV retinitis, it can also be seen in immune-mediated reactions to infections, inflammations, neoplasms. What is interesting to note is that it has also been reported after blunt ocular trauma, traumatic endophthalmitis, and after extensive literature review, we found one case also reported in a retained intraocular foreign body. Our 35-year-old male presented with a left eye complaints of a painful loss of vision since 2 days. He gave a history of trauma to the eye while hammering an iron bearing, wearing no protective glasses. He had no viral prodrome, previous systemic or ocular complaints. On examination, the right eye was 6/6 vision and examinations were normal. In the left eye, however, vision had come down to perception of light and projection of rays accurate. Conjunctiva showed congestion with a focal superonasal hemorrhage. Cornea was clear, but the lens showed early cataractous changes. On dilated fundoscopy, we found dense vitritis with inferotemporal preretinal hemorrhage. We investigated with a USG scan, and this peak on the USG-A corresponded to the USG-B hyperechoic area anterior to the retina, suggestive of a retained foreign body surrounded by vitreous hemorrhage, which was confirmed on X-ray, which showed a single small metallic foreign body. So after a negative serology and blood workup, we started him on topical antibiotics, steroids, and cycloplegics. And the patient was planned for a 23-gauge pars plana vitrectomy to clear the vitreous hemorrhage, after which we could visualize the metallic foreign body. And interestingly, beside it, we saw what seemed like frosted branch-like vasculitis. So after laser around the foreign body, as well as the entry site in the temporal area, in the nasal area, we gave a PFCL cushioning and retrieved the foreign body with a handshake retrieval technique, and silicone oil tamponading was done to close the case. Vitreous specimen was sent, though it was negative. Patient was started on oral antibiotics and steroids, which were tapered over 6 weeks. So this color photo shows the 1-week follow-up, which shows the laser marks, but complete resolution of the perivascular exudation, which appeared to be frosted branch angiitis. The same blue autofluorescent image of the same area shows that the silicone oil is in situ, seen by the artifact. The retina is on, and there is no recurrence of the vasculitis. So what we want to highlight is that frosted branch-like vasculitis can be caused by a number of entities, and it is basically due to an intense inflammatory reaction. We hypothesize it is due to plasma kallikrein released due to hemorrhage, breakdown of the blood retinal barrier following trauma, as well as the presence of a foreign body. The fact that there was no underlying predisposition that this patient had for a frosted branch vasculitis and the temporal association between removal of the foreign body and resolution of the frosted branch angiitis further supports our theory. What we can do to go a step beyond is a metallurgic study of the metallic projectiles to know which specific metal causes this reaction, acting as the antigen. My take-home message is that prevention is better than cure. We should make the patient aware that safety glasses are to be worn while operating power tools. You snooze, you lose. Early removal can prevent extensive damage to the vascular and ganglion cell layers of the retina. But better late than never, because late removal will still prevent chronic degenerative changes. And slow and steady wins the race. After ruling out any contraindications, long-term steroids to prevent or treat the complications of a metallic foreign body should always be considered. Thank you.
for
nice.
finishing on time.
It was a nice presentation.
Thank you, ma'am.
Yeah. So we can. Any questions from the judges?
Thank you, ma'am.
So just a question, one question, Paridhi, and that I wanted to ask you. So what is the wound entry wound? At which level it went?
So it was superonasal, and the foreign body was seen lying inferotemporal, as in the fundus photos that
Okay,
we
it was
took for
not to the
follow-ups.
cornea. It was not to the cornea.
Not through the cornea, so it was scleral, which was covered by a subconjunctival hemorrhage when the patient presented.
Okay. Another thing, did you give any intravitreal treatment during the surgery after removal of this thing, posterior segment?
So we did a IVT-assisted PPV, but apart from that, we did not give antibiotics intraoperatively. We started him on topical, and after cultures, it was negative. So we were not expecting an endophthalmitis,
Yeah.
but
Actually,
oral ciprofloxacin 750 was given, sir.
okay.
BD.
I think most of the cornea retina consultant here will agree that any intraocular foreign body, when removed by any means, the posterior segment should be fortified with medicines.
Yes,
So we
sir.
have brought a medicine, this foreign body through the vitreoretinal posterior segment approach to the anterior segment, and then you have taken from handset technique. So that means the two compartments are already
Can be
involved.
contaminated. Yes, sir.
Okay. Okay, thank you.
Excuse me, one more question. How long you give the steroids, oral steroids?
So, ma'am, 6 weeks. We gave it for 2 weeks at full dose, 1 mg per kg, and then we tapered over 4.